What happens if we flip the traditional way of sharing medical information to the wider population on its head? What happens if instead of letting algorithms or the zeitgeist of the moment order our social media feeds, we go straight to the source of clinical medicine and ask practicing experts what they see day in, day out, and give them an unedited platform to help disseminate practical medical information straight from the specialist? Thank you, Professor Stephen Till, for coming today for this recording of Straight from the Specialist. Would you mind giving a quick introduction of who you are?
Certainly, yes. So my name's Stephen Till. I'm consultant allergist at Guy's and St Thomas's Hospital. I'm also a clinical academic, so I work for King's College London.
So it was my friend, Dr. Cosper Tredes, who introduced us. He just said you explain things so brilliantly from basic principles. So just a little introduction as to why I've invited you.
Oh, thank you. That's
So-
very kind.
So you know the format of the conversation. It's not really an interview and it's not really a teaching session. So hopefully you won't mind if I interject and I ask really silly questions. But as a sports and exercise medicine consultant, I'm happy to claim that I know very little about the allergy world. But that's the beauty of being a doctor, whether that's a consultant, a GP, or a junior doctor, is that we're always on this forever journey of continued CPD.
Yeah, I agree.
So, well, we'll start with our base level question is what I say one thing, but during our preparatory work, you've come up with a few options to talk about, and I don't want to edit any of them out. So what are the few things that you want to share with the general population?
Well, so a couple of things. The first thing I would like to comment on really is about early introduction of food. So as an adult physician, I see patients often with very severe lifelong food allergies. Typically, I see patients from 16 years and above, and at which point these allergies are really then fixed and essentially lifelong, unless some new treatment comes along in future. And now there's very specific guidelines, which are quite simple to follow, about early introduction of foods around the time of weaning. So it's not something I do as an adult physician myself, but I do see the consequences of that. And so we know now from research that it's very important to introduce allergenic foods as early as possible into the diet. And this does seem to work very well, particularly with certain food allergens like peanut. The immune system around that time still seems to be programmable, if you like. So if you're going to go down a pathway where you're going to become allergic for something, you can deviate it at that young age. So this is really something that my pediatric allergy colleagues push very hard, but it's just getting there early enough with the kids around about weaning time of around about 6 months and getting these foods into their diet, which is so important for kind of the rest of their life and minimizing their chance of severe food allergy.
So we're not talking about children, sort of 6-month olds, who are exhibiting symptoms of allergies. We're talking about just generally all children. The more you wean them onto these allergenic foods.
So any child has the potential to become food allergic. It is much more common in children who've got eczema, particularly the more severe types of eczema, they're more likely to become food allergic. And so it's correct in that kind of area. There is a group of children who do need to be tested to check that they haven't already developed food allergies before you then introduce them.
And that's how they get to the secondary care with the pediatrician.
Yeah.
But you're still talking about brilliant general advice for everybody is to introduce these foods. What are those foods?
Yeah, so the main allergenic foods that we worry about are nuts, milk, egg, but also other food allergens as well. I don't know if this is a good time to mention that if you simply Google British Society for Allergy and food introduction for children, it will pop up. There's an excellent PDF information leaflet which talks about which children you can just introduce those foods in, which children probably need to be tested before you do that, and how you do that, and how much to give them. And also for parents who themselves have a food allergy, how they can do that safely.
Right.
So if you have a peanut allergy and you have a young child, how are you going to give peanut to them without, obviously that's a concern, but the leaflet explains about that. So
Okay, brilliant.
It's a great resource.
Thank you. Is that a resource that's accessible to patients?
It's
as well as-
designed for
Okay.
parents, yeah.
Okay, great. Thank you.
You're welcome.
And you have another one which I particularly love, only
Yes.
because if you want my little bit, I'm often on the tube, traveling the tube, and I see these Randox adverts for sports performance bloods, and I have
Yes.
my opinion about the general public self-directing these medical tests and interpreting them, being left to interpret them by themselves, and I have an opinion about that. And then yeah, we were earlier speaking about something that you brought up, which I
Yes.
think is along the same.
So I think it's really, really important actually. So there are blood tests which are pretty widely marketed for food intolerances, but also for allergies as well. So they measure different things. So the most common one that I see that patients show me in clinic, and they'll
Mm.
often bring a printout and show me these results, measures a particular type of antibody called IgG.
Mhm.
So this is like the most common type of antibody which we have in our circulation. And so this test measures IgG to different food groups. And the claim is that this indicates an intolerance to these food groups and therefore something you should consider avoiding from your diet. So certainly as allergists and immunologists, we don't think there's any diagnostic value for these tests at all. They've not really been validated properly in large scale studies. And also this antibody is made normally as part of your immune system response against things that you're exposed to. So food is basically foreign protein that you're eating and
Mhm.
you make an immune reaction to it. But it doesn't mean it does any harm. This is just part of your normal immune response. So these tests are quite expensive as well. So I really don't think that it's something that people should waste their money doing, but
Yeah,
also it has consequences in terms of, avoiding things in their diet which are important nutritionally. So
yeah. It
it's a
seems to be
double-edged
part of
sword.
the health and wellness sphere, and that's why I started this podcast. But you were telling me how there's a company that advertises in your gym.
Yeah,
I see
exactly.
these Randox
Yeah,
pop-up adverts and on the tube.
yeah,
So they're far and wide reaching. And
yes.
I think it is really important for us as clinicians to be able to explain how useful or how useless these tests are. So you're saying that it's not useful for the GP or for you at all. We'll have to
Not at
start from
all.
scratch. So
Not
it's not even a useful screening test.
It's not a useful screening test at all. And I think one of the problems with this is that the
Mhm.
way it's presented is it has some kind of sciencey feel to it,
Yeah.
and it looks
It's sciencey.
sciencey. Yeah, it
Yeah, so it's
looks
not real science.
no, it looks plausible, and there are some other types of testing which are rather similar, and yeah, these things I think if you're
They
not
sound
involved.
intelligent.
Exactly, and it sounds like there's some scientific basis and evidence for it, whereas in reality, that's just not the case.
Okay.
The other,
Because these things are
yeah,
complex. And
yeah,
I think that's what I really want to
yes,
hammer home to people.
yeah. So, well, there's the other test, which is I'm seeing more and more of now, is patients actually having IgE testing. So IgE is a different antibody, and that's one that is associated with allergic reactions to things. So, if you have
Mhm.
hay fever, you have IgE to grass pollen. If you're peanut allergic, you have IgE to peanut. And so these, that is the correct antibody to measure when you're assessing someone for allergic reactions, but in a specific context. So we only do that test when there are clinical features that suggest that the result could be relevant in some way.
So
And
the screening is actually the history.
in allergy, the most important thing is the clinical history. So if the
So the
history is
patient's complaints.
exactly, so if the symptoms that the patient describes if it's impossible for that to be caused by an allergy, then doing allergy tests or IgE tests more correctly or skin prick tests is just not appropriate. It's
Hmm.
no more useful than doing an ECG on someone who's broken their ankle, doing the wrong test.
Correct. The heart
Yeah,
scan, the heart sort of
yeah,
reading thing. That's
exactly.
a really useful takeaway
So
because
forgive me if I could add one thing,
sure.
which is that so the testing itself is the correct antibody, but the problem I have is not only is it done in the wrong context, but the results I'm seeing are extremely unreliable. So when we do then have to investigate the patient, the results I'm getting are completely different. So that's my concern, is the sort of quality control around these tests in this sort of sector. It's just not meeting the basic requirements because the results are so different when we use our
Why?
well-validated tests that we've run for years, run
Yeah.
by approved laboratories.
Yeah, and I think that's key because the laboratories have these checklists and they're approved and they're validated. And they've got a network of these professional bodies that keep them in line. But when you're outsourcing this work to just an online business, they
Yes.
don't necessarily need to adhere to those strict.
Yes, and if we have test results, which happens sometimes, that don't fit with the history, and it looks a bit like there might be a methodological issue or
Mm,
problem with a batch of tests, that gets investigated at a very high level by our
mm,
immunology laboratories, and there's always a kind of process for checking that and feeding back the results, and then it's corrected sometime, if it is an error, and yet these other kind of technologies, which I really don't know how they're doing these assays because they don't discuss it. There's no way, there seems to be no way of sort of correcting this at all.
or feeding back.
Or feeding back, or it doesn't seem to be regulated or anything. So
Yeah, because
big
unfortunately, if you
problem.
do get that high level, you then exclude the group. So it really
Absolutely.
impacts your quality of life.
Yeah. And occasionally some patients will see results on it and think that's just doesn't make sense because I eat that and I don't get any symptoms. And
Mm.
then they start to kind of question the whole thing. So that sometimes happens. But you do see patients avoiding lots of different foods on the basis of spurious test results like this.
Yeah, yeah. Okay, thank you. So the next question is, what would you like to share with your GP colleagues? So I think along the lines of those IgE tests,
Yes.
that's something that I'm hearing is being done
Yes.
in general practice.
Yes. So I understand that GPs are obviously trying to help their patients and do these tests and possibly avoid need for referrals and what have you. I guess something which we encounter quite a lot in our practice is again tests which have been done perhaps slightly out of context, but also the problem with these kind of tests is that they do have their idiosyncrasies, and you do get false positives on these tests.
Hmm.
And it's really only by seeing these tests kind of in quite a large volume and seeing patients being familiar with the kind of outcome of these investigations that you know how to interpret these things. It's a lot of pattern recognition. I mean, that basically as an
That's what a
allergist,
specialist
that's what that
is.
exactly. It's
You're the
exactly.
expert
And
pattern
and
recognizer.
and so I'd say to GPs is be very cautious about running IgE blood tests in primary care. You
Hmm.
have to really have a sort of very clear endpoint about what you're going to do with that information when you get it, or at least have someone that you've got easy access to be able to discuss the results with. So if you do, I wouldn't encourage this, but if you do get in a situation where the results seem difficult or implausible, or you're not sure what to do, then perhaps contact your local allergist through the advice and guidance system
Okay.
and send a copy of the results and ask for help. So I give you an example. For
Mm.
example, I would estimate just from my clinical practice that something, I would say somewhere between 10 and 20% of the population is now IgE sensitized to birch pollen. All right.
20%.
But between 10 and 20%, I would say, just a kind of ballpark figure. Um, Every patient that I've seen who's birch pollen sensitized will test positive on a mixed nut IgE blood test. All
It's
right.
crossover.
So, because the hazelnut extract contains a molecule that is basically almost identical to birch pollen,
Mhm.
so that causes the test to light up. But bundled within that test, you've got peanut, Brazil nut, other nuts, and then it's not uncommon then for patients to get prescribed EpiPens, being told to avoid all nuts. Perhaps in an ideal situation they'd be referred so we can sort that out.
Mhm.
But these patients almost are never allergic to nuts, so I've seen patients been carrying around EpiPens for 10 years, going to restaurants, telling everyone that they're allergic to nuts, being very anxious about trace exposure, which
Mm.
another issue, but tends not to be a problem, or limiting their travel because they're then anxious about the possibility they may have
Of
a
course.
severe reaction.
Yeah.
So it has real consequences, these kind of tests, the false positivity. But again, something that we just see all the time. So, it's something we can sort out very easily.
But who does the GP refer and who do they self-manage?
So a GP, well, ideally would refer to a local allergy clinic where this would be bread and butter really for them. But I appreciate that in large parts of the country, there's
Yeah.
not really good allergy provision.
Uh-huh.
Um,
So you're talking about, and this probably is veering
mm,
off topic, but are you talking about the severity of symptoms really directing when they get to the secondary care level?
yes. So in general, patients who have severe reactions or reactions with systemic features
Hmm.
really ought to be referred to an allergy or an immunology
Hmm.
clinic
Hmm.
for that to be investigated. Alternatively, when patients are starting to avoid major food groups and they're anxious about it, and often this is based on some reaction, but it may be relatively minor issue like what we call pollen food syndrome. You get a bit of itching in the mouth, but if that starts to impact on their diet and
Mm.
they become very anxious about it, then also those patients
Mm.
can be investigated and reassured as well.
But there are some conditions where you were talking about allergic rhinitis,
Yes.
where you think, well, actually, confidently, it can be managed
Yeah.
outside of
I mean, it's
secondary
just
care.
the numbers are so vast. You
Yeah.
got roughly, 30 to 40% of the population got some degree of allergic rhinitis. So it's the commonest immune disease in the UK, basically. And about half of those have symptoms that affect them in terms
Mhm.
of, their concentration or sleep or just interferes with their quality of life and what have you.
Mm.
And those patients, most of those patients are not well managed. They're not adequately treated with
Mhm.
with basic measures, and that's something that is really easy to do. And there's an abundance of kind of online materials. There's for example, in our part of London where I work, there's the Southeast London allergic rhinitis pathway that you can Google and find,
Right.
which talks about the simple measures that you can do, just proper treatment with antihistamines, but also very importantly, just using a nasal spray. You can get these over the counter or prescription one, doesn't matter, but regular use of a steroid nasal spray, which has a infinitesimally small amount of steroid in it with virtually no systemic bioavailability,
Mm.
can dramatically improve quality of life.
Oh,
And
yeah, Dymista for me
yeah,
personally. It's just
exactly.
changed my summers. I
Yes.
smell flowers,
Right.
and I think for 35 years of my life, I've never smelt a rose, and so
Yeah. And it's I think it's something which is often trivialized by people who don't have it, but having hay fever or bad hay fever in
Mhm.
the spring months or the summer months is miserable. And
Mhm.
I have patients who virtually don't want to go out then, don't go to barbecues and things, or it's just
I
it's
know
just
people who have
horrible.
left the country.
Right, exactly. And these
Mhm.
things are you know, many of these patients, we see them, have not
Mhm.
actually reached first base in terms of management
Mhm.
before they've come to see us.
Mhm.
And it's something that is, I think, quite easy
So
for
it's
GPs
very
to do.
easy to manage. It
Exactly.
doesn't need to be seen in secondary care. The treatment plan is all available for GPs online, and
Exactly.
it's just a matter of confidence. But there isn't anything more or specialized that you're going to add to allergic rhinitis treatment. Is that
So
correct?
so yes, they can manage most of it based on simple measures and stuff that's available online, guidelines and things. And I would suggest just investing a little time just to read
Yeah,
those
of
because
course.
there's so many patients. It will be probably one of the best things they'll do in terms of
Yeah.
saving time. But that's not to say there isn't a role in secondary care
Mm-hmm.
for allergists managing allergic rhinitis. So when patients have really terrible symptoms
Mm.
and it's not adequately controlled by this nasal steroids and what have you, and optimized medical care, then we do sometimes desensitize patients. And there are products which are licensed and approved in the UK,
Mm-hmm.
which are highly effective and can be used for that.
Mm-hmm.
The problem really is not that they is the not the efficacy, 'cause they work really well. It's access to those treatments because patchy NHS cover over the UK, and there's not a very robust mechanism for paying for these treatments, which currently tend to be funded by trusts rather than through NHS England. So
Okay. But
that's
if you
sort of
want to self-fund, how do you access these
yeah.
and what are
So
they?
so you can access it privately. So you
Mhm.
couldn't self fund through the NHS, but yeah, you have to find an allergist and see them in the private sector to do
Okay.
that.
But I should have optimized my NHS GP allergic rhinitis treatment, been on that for a few years, failed,
I
and
think
then
at least one pollen season, if it's
okay,
seasonal,
okay.
with using those treatments daily. And to be honest, by the time patients come and see me for desensitization,
Mhm.
they've usually done that,
Okay.
and it's still really affecting them. So
Okay.
yes,
And so what is this desensitization therapy?
yeah. So principle is that if you can re-expose someone to the thing that they're allergic to,
Mhm.
if you can do it without causing them any harm, because of course you're giving them the allergen, if you can re-expose them at high enough doses for a long period of time, you change the type of immune response that you get to the allergen.
Mhm.
So we talked about IgE antibodies earlier.
Mhm.
So it changes the type of antibodies that you make to the allergen, which then dampen the allergic response. So
Okay.
historically, this was done by injection. So you'd get an extract of the allergen, you'd inject it into the skin, and you'd gradually start with a tiny dose because you can cause reactions by doing that, even systemic
So it
like
needs to be in a
reactions.
hospital
It needs to
setting.
be done in a hospital, so it'd have to be increased gradually, and then you'd have injections roughly every month or so, then for a total of 3 years. That's the kind of traditional way of doing it. But the new treatments for pollen allergies and dust mite in particular are a dissolvable tablet which is placed under the tongue, and that's much better in terms of the safety. So it's really rare to get severe reactions to that, but it's a very effective way of getting a lot of the allergen into the immune system and triggering a protective response. So that can be done after the first dose. That can be done at home. But the first dose has to be done under medical supervision, and it's normal to get itching for about 10 minutes, but that stops happening after a few weeks. And yeah, that's
And how
highly
do your
effective.
patients respond to this therapy?
So really, really well. I'd say the overwhelming majority of patients have a very significant reduction in symptoms and also their need for medications as well. So you have to start it about 4 months before the pollen season. So I'm now starting people on the grass pollen, and we'll finish.
When does grass pollen
So grass
season hit?
pollen season hits in the UK typically in May. It's been getting a little bit earlier the last few years, perhaps because of the warmer weather. It can be mid-April. So we're starting it up until mid-January with the with the grass pollen. That tablet does have to be taken every day under the tongue, but again, you can just take it at home. So it's not a trivial thing, but it's highly effective. And patients tell me things like this can be life-changing for them, which is quite a big term to use in the context of hay fever. So it really can work extremely well. Really important thing about these kind of desensitization approaches, though, is that although you treat for 3 years, when you stop it, most patients it should carry on working at least for some years after that. So there's a kind of
Oh, great that you carry on.
reprogramming effect that happens. And there's with tree, we tend to start a bit earlier because the tree season can start really beginning of March. I'd say is kind of typical, peaking up towards Easter.
Yeah.
So we've finished all that kind of starting of the tree pollen desensitization this year.
Okay, good.
So-
So it's great knowledge for planning for the upcoming year.
Yes,
Yeah.
yes.
Okay,
exactly.
thank you. Is there anything else you want to share with your GP colleagues, or should we move on to the specialist level?
Well, perhaps if you allow me, one other issue which I wanted to
course.
mention, which I think may be quite useful, something which I think is really quite common in primary care, judging by the numbers of referrals we get, and that's urticaria. So urticaria is a condition where you get itchy raised wheals on the skin, and understandably, patients who have that condition, and also a lot of clinicians who see them, think it's being driven by an allergic process. And so those patients will often be referred for allergy investigation or allergy testing, and the patients will often be worried or thinking about what might be triggering those symptoms. And I think it's one of those areas it's really worth kind of understanding properly, because it's not an allergic process in the vast majority of individuals. Rather than an exogenous allergen driving the response, it's something endogenous, which we believe that in most individuals, there's a type of antibody which sticks to the cells which release the histamine and cause the wheals to activate them, which is what we call an autoantibody, which is otherwise harmless, but it just does stick to those cells in the skin in particular. These cells, by the way, are called mast cells, cells which have histamine granules in them. And these antibodies stick to the surface, the receptors on these cells trigger those cells to release the histamine. So the natural history is that this does usually settle down and go away. It can be months, can even be a couple of years in some patients. And management is really only about antihistamines or symptomatic treatment. I mean, not just antihistamines, there are other things that we can do in the severe cases. But understanding that this is not an allergy-driven process I think is very important for patients, so they don't have this kind of futile search for what the trigger is, and also come to appointments expecting they're going to be investigated for allergies when it's not an alert, because obviously sometimes patients waiting months and they think they're coming for allergy testing, but actually we draw pictures and tell them about what's causing this process. And actually most of the time, I'd say that's kind of very useful, that knowledge for them. It allows them to kind of move on in the process, and also being reassured that it's likely to go away in the future. But actually, it's also, a lot of this stuff could be managed very adequately at primary care. And again, there are guidelines for primary care. Again, Southeast London urticaria treatment pathway, you can Google it. and it will come up, and it's got an algorithm for managing this kind of stuff.
Thank you for the resource.
You're welcome.
So finally, what things would you like to share with your specialist colleagues?
So I think one thing that might be useful is to address a few misconceptions about allergy, which seem to still be quite pervasive amongst colleagues. Some of these may be already debunked, but by
So
people that
specialists, I mean, yeah, any colleague who's secondary care, so
yeah,
hospital
fine,
level. Yeah.
exactly. So for example, again, I think many doctors will know this, but the prevalence of true penicillin allergy is far lower than what you see on the hospital records. I understand that that doesn't necessarily mean you want to give these patients antibiotics, but it's important to know that. And if it's important to know if that patient really does have penicillin allergy, then you could refer the patient to an allergy clinic. There is also an excellent resource now, a guideline published by British Society of Allergy and Clinical Immunology, which is open access, about delabeling patients outside a specialist allergy setting. So if you're in an area where you can't access an allergist, then you can use that algorithm in that paper to assess who's low risk and how you might delabel them, by, for example, by supervising a dose. So that's a really incredibly useful practical guideline for colleagues. But yeah, if you work in a trust where there's an allergist, we're happy to see those patients and delabel them for you. Also, this issue about cross-reactivity between cephalosporins, another major broad-spectrum antibiotic class, and penicillin. It's not 10%, as people still think. It's far lower. That's based on old antibiotics that were used in the past. The cross-reactivity is far, far lower than that at the present time. So these kind of things, again, these sort of build themselves into medical education. They get passed on. They kind of, again,
Medical misinformation.
misinformation, and they persist, and they're very hard to undo. But a lot of this stuff is really not true. Other one which comes up from time to time is IV contrast reactions and links with shellfish allergy or iodine allergy. So IV contrast do contain iodine that's covalent bonded to the contrast molecule, but you don't react to it because of iodine allergy, and it's got nothing to do with shellfish. And so this has been totally debunked. So you don't need to, if you do that, you don't need to ask patients about shellfish allergy. If someone's prawn allergic, you don't need to think, oh, we won't give them contrast or anything like that. If patients have got a history of reactions to IV contrast, so it's mostly non-IgE mediated. So
Non-IgE.
non-IgE mediated. So it's not like the mechanism of your reaction to, say, a peanut, or to most patients who have allergic reactions to moxicillin. It's a different mechanism. But what we will often do in those patients is give them a challenge with a different compound, with a different IV contrast, like a graded challenge under supervision, mostly for reassurance purposes, so that patient can have their scan with contrast, particularly, obviously that's sometimes clinically essential.
So if a patient receives one after the other of IV contrast, and they have had a bit of a response, does that response get worse the more times you're subjected to it?
No, it doesn't. So again, that's another kind of area which is misunderstood. This and something which is often told to patients in secondary care, but elsewhere, not just by doctors but other healthcare practitioners, is that this kind of misconception that allergic reactions get worse every time.
And I was taught that at medical school.
Yeah, exactly. And it actually is not uncommon for patients to come to the clinic and they've had a nasty reaction to something, and they're then in a state of heightened anxiety, thinking that the next one is going to be worse, right? And that can often be can be source of some emotion in the clinic. Patients can be very upset about it because they feel they're living on this knife edge. But it's completely untrue. Okay, there's no evidence that allergic reactions get worse each time. So if you are allergic to something, there are many things which affect how bad that reaction is. So of course, the dose of exposure, if it's hidden and you manage to have quite a significant quantity, perhaps it's because it's hidden by some kind of spices, say in a curry, or perhaps for other reasons, your acuity is a bit less, like maybe you've had a bit of alcohol, so you've not noticed that you've eaten something that's laced with a lot of this allergen. So if you have a lot of it, but there's also cofactors as well. So things which, if you like, amplify the reaction or enable the reaction. So there are some food allergies, for example, that mainly occur when you've eaten the food and then do exercise. But even
Oh, so exercise works as a catalyst.
So exactly. So for example, wheat dependent exercise induced anaphylaxis,
Oh, that's a
right?
fancy term.
So you eat wheat, and if it's enough of the allergen and you do exercise, you have the reaction. So a classic story would be you go out for a pizza and you walk home from the restaurant, you start to break out in hives, and then that may or may not progress to a more severe reaction. But that also happens, although there are certain food allergens that are very strongly exercise associated, like
Hmm.
wheat and crustaceans. For other food allergens, those cofactors can also work, but to a lesser extent. So, for example, if you had exposure to peanut and then went for a run, that might increase your likelihood of having a more severe reaction, or any reaction, but also a more severe reaction. So dose, cofactors, of which there are others apart from exercise, those kind of things affect it.
Very
Also,
interesting.
if you eat it on an empty stomach,
Uh-huh.
if you have the allergen in like liquid form, it's absorbed more quickly. So, things like a
Right.
smoothie, or I saw a patient last week who had a peanut butter milkshake, and the
Uh-huh.
reaction was more intense
More
than you would
profound.
normally
Yeah.
expect. So many factors that affect severity of allergic reaction, but there's not this relentless stepwise progression in
Okay. Good
severity.
to know.
So during the early stages, when you develop the allergy, you might obviously you go from a state of being non-allergic to allergic. So there is a kind of initial transition where as you become allergic, but once you're allergic, there's no progression after that, if you see what I
Okay.
mean.
Okay. Okay. But things that make it worse are the
Mm.
ones you just can you, you were telling me just before of a really interesting, well, I mean, we call it a case study, but I think it's just a lovely example in a story format of that exercise
Oh
induced
yes,
wheat. Yeah.
yeah. So
Because this is a really lovely way that I guess we can demonstrate that you are the specialist. Because
yes.
as soon as another colleague is telling you about this case, you knew exactly what it was. And
So this is, I mean, one of the things I enjoy most about being an allergist is that, you know, that, and I guess it's true for other specialists as well, is the pattern recognition and realizing that we can add a lot of value in certain situations which
yeah,
are
for
not
sure.
apparent to others. So,
Yeah, for
and
patients
it's
don't believe
very,
me when I know what it is. And they're like, well, don't you want to do a scan? I'm like, no, 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 I know.
yeah, exactly. And it's really rewarding knowing that you can add value like that, and
Mm.
help people. So that was just an example, yes, of a GP in the Highlands who emailed me saying, was it possible to desensitize someone to tree pollen because he had a patient who was getting anaphylaxis? So, well, so tree pollen doesn't cause anaphylaxis. That's the first thing. It causes
Okay.
allergic asthma and hay fever. You can't, very difficult to have anaphylaxis to an airborne allergen like this. So I wrote email back to him and said, could you tell me a little bit more about what's going on? He said, well, yeah, this patient, every time he goes out to chop logs in the forest, he gets anaphylaxis. So I said to him in the email that most likely explanation was food dependent exercise induced anaphylaxis, and he should send an IgE test off for omega-5 gliadin, which is probably the most common trigger we see in allergy clinics, which is a wheat molecule, and it was positive. So that was a good example. But another one which I think is kind of different, but also shows how important this is. I had a patient came from another remote Celtic country, who for the last couple of decades had been collapsing when he was playing golf, particularly. And then it happened in some other circumstances. You investigated by cardiologists locally and had all the various kind of, appropriate investigations for that, which were all negative. And I believe that his daughter saw me give a talk about allergy, and she got her father to come over for an appointment. Again, within 5 minutes, the diagnosis was obvious. It was wheat-dependent exercise-induced anaphylaxis. But this poor chap, his wife wouldn't go on holiday anywhere. They wouldn't travel internationally and things like this. So just put him on a gluten-free diet, and it's not happened since. So, they've living life and enjoying their retirement, going on cruises and things now, which is lovely to hear. So,
I mean, that was
yeah.
one of the first things you asked me about when we first met. And of course, I consider myself more educated now. So thank
Yeah,
you.
I'm always, a bit surprised that people don't see it a bit more actually, but it's not that common. But especially people, clinician like yourself who sees obviously athletes and what
Yeah.
have you, I'd expect it. It's like I ask personal trainers, do you ever get people collapsing in the gym with hives? And no, it's not a common disorder, but of
No,
course,
yeah,
it's
yeah,
the
that's quite reassuring. It
yeah,
isn't that common. And the
yeah,
first thing we think about, really, with all the popular case studies of on-pitch cardiac arrest, that
yeah,
cardiac causes.
yeah, yeah.
Yeah. No, thanks for sharing. Are there any other things you would like to share?
Um,
You've got a
yeah,
list, and I almost don't want to edit any of them out because I think
yeah.
they're all sort of
I
really
suppose
useful
there's a kind of
explanations.
there's for hospital-based colleagues. One other thing is about trip days measurements I'd like to highlight because
Okay.
so we in the allergy clinic we're often kind of detectives trying to piece together an event after the event. So we're trying to kind of like work out the history, the chronology of what's happened.
And you're trying to chase all these blood
Yeah,
tests done in
and
several
and
centres.
and trying to firstly, was this an anaphylactic reaction or not?
Hmm.
And if it was, then there's a lot of investigation that needs to go into that and managing and preventing that in future.
So sorry,
Um,
just for the basic
yeah,
clinician like myself,
yes,
you're talking about allergic anaphylaxis and
yes,
tryptase, which is a blood test
yes.
measurement.
So
When is it useful?
exactly. So essentially, when you have a severe allergic reaction, these cells which release the histamine and cause the reaction, they release an enzyme called tryptase,
Hmm.
and you can measure that in the bloodstream.
Hmm.
And the peak is about 1 to 2 hours after the reaction starts. Okay,
Hmm.
so if you've got an increase in tryptase, then it's really good evidence that someone's had anaphylaxis. And that's important to us as allergists because we may see a patient months later
Hmm.
in the clinic, and the
Just
history,
because of the waiting lists.
well, yeah, or for a variety, for maybe all sorts of reasons. In fact, we don't want to see patients too early because within a month you can get false negatives on the testing after anaphylaxis, but it's a
Ah, okay.
separate
So
issue.
there is a clinical
Yes,
reason why you see them in 2 months.
but often it is months afterwards,
Hmm.
and the details of the event may not be particularly clear. I mean, the patient may have lost consciousness, for example. There's a lot going on at the time, so it's kind of difficult to know what's going on. From them, we may have a discharge summary, which may be quite sparse on details, understandably. And the first question we ask is, did this patient have anaphylaxis or not? Because there is a differential diagnosis.
Hmm.
Patients with non-allergic urticaria do sometimes develop also lip angioedema, and they do go to A&E and have vasovagal episodes, or they may have hyperventilation and feel lightheaded and things. So it's not uncommon.
And this is the urticaria that you're
This
talking about earlier.
exactly,
That has
exactly.
nothing to do
So
with
all sorts of other kind of issues or adverse reactions to medications and things
Mm.
that can, to some extent, mimic anaphylaxis, and that becomes even more of a grey area when you see the patient later on.
Hmm.
And so having a tryptase that is positive,
Hmm.
that's been measured acutely,
Like a
is
peak tryptase.
yeah,
Yeah.
peak tryptase is incredibly valuable for us,
Okay.
particularly when it's positive. And that you can have negative tryptase in anaphylaxis, but a positive tryptase is very valuable. But those results are always like we spend a lot of time integrating that into our kind of assessment and chasing up results from hospitals and things. And I have to say that most patients who present like that, they don't have a tryptase sent.
Okay. So when is the tryptase meant to be taken?
So, well, so it should be taken
So
as
this is
soon
mainly
as
for
you,
A&E
yeah. So
conditions.
basically, as soon as you see the patient, but the peak is 1 to 2 hours afterwards. So if you do one before, if it's before an hour,
Uh-huh.
then it needs to be repeated between 1 and 2 hours is when it peaks. And then a third tryptase, which you don't need to do in A, is the convalescent one, but we do that in the allergy clinic later on. So
Months
yeah,
afterwards.
exactly.
Okay.
So we might, you may get tryptase come back positive, could be like 25 or something. Then we do it in the clinic, it may be 4. It's concrete, objective evidence this patient did have anaphylaxis.
Fine. So it's a pattern. So it's
Yeah.
sort of the triage nurse potentially. It's one a few hours into their A&E stay. Maybe they were in resus.
Yes, exactly. In
doing
fact,
that.
I'm always a bit surprised it's kind of not built into a pathway
Well,
in
you were
A&E.
telling me it was
But
in the ALS.
no, in the Resus Council guidelines.
Resus
Yeah. So
Council
if you look at the full
guidelines.
PDF for that and the investigation section, yeah, it
Because
is
it's
in the
detailed
guideline.
there.
It is in the guideline. Yeah. So
Right.
if you don't send it, you're not following the guideline. Please send it.
Thank you for sharing that with us.
Is there something else? I was going to talk, yeah. So one other thing I was
Mm.
going to talk about is just what an allergist is, because
Yes,
I think
please.
there's not many of us, and a lot of people don't really know what an allergist does. So
Well, sorry,
there's
just to
yeah,
interrupt you here, and I'm so terrible at speaking over people, so
no, that's all
apologies.
right.
I get so excited though. The reason why I've started this podcast actually was based on a conversation that I had with Cos. And I probably told you about it when we first met. But I'm a sports and exercise medicine physician.
Yes,
Cos is a pediatric allergy specialist, and we'll share our little nuggets of
yeah,
information. And we both went to the same medical school, so similar levels of training, both trained in London. And yet we were sharing these clinical pearls of wisdom that both of us were just gasping at.
yeah,
And one of the things that Cos told me about is how they found out about microdosing with peanut allergies and
yes,
the what's it type crisp equivalent in Israel, and how an Israeli doctor, managed to piece things together. And I found it fascinating, and that's what that was the catalyst for this podcast production, because actually, as specialists, we can share some really useful information. And sometimes we are stuck in our silos. Sometimes I
mhm,
go to sports and exercise medicine conferences, and when would I ever end up in an allergy conference? Never. But apart from lunchtime conversations, I don't really think that there's a natural way in which clinicians from other specialties, chat about things other than our social networks. So yeah, so thank you for almost being or coming from a specialty that has provided me with lots of food for thought. Yeah, thank you.
So, shall I tell you a bit about
Yes, please
about
do.
allergy? So what we do. So you already mentioned. So there's a separation really between pediatric and adult allergies. So
Mm.
you have to go through, like in adult, through the normal medical specialty training pathway. So now it'd be like IMT, and then you apply for training post. So completely separate. Pediatricians go through their pediatric training and what have you. So the specialty training structure has just changed, by the way. So they've merged clinical immunology and allergy to allergy and immunology. So it used
Mhm.
to be separate. Immunologists used to do allergy, but also immune deficiency stuff, whereas allergy was like, hardcore 5 years of allergy training, drug allergy, food allergy, all sorts of branches of allergy. So it's now merged, and hopefully the numbers as a result will now start to go up, of qualified consultants. But we really have small numbers in the UK.
How
So,
many do you have
oh,
consultants?
yeah, adult consultants probably, it's maybe, I, I couldn't tell you, maybe 20 to 30, something like that.
Oh, so
In the,
you're a real
right, yeah.
rare breed.
So what do we do? So we, I suppose the space that we fill that other people don't fill is in diagnosing severe allergic reactions to foods, medications, insect stings, also doing desensitization treatment. So, for example, if you get stung by a wasp and you have an anaphylactic reaction, an allergist is really going to be the only person that's going to help you with that. So, we do desensitization for 3 years, which is extremely effective for that. We do that for bees as well. So, that kind of thing. We also do respiratory allergies, so asthma, allergic rhinitis. I also work closely with dermatologists specializing in adults with eczema. They manage all the biologics and the systemic therapies, but the kind of allergic comorbidity side of it is where I get involved with.
Hmm.
And again, specialists are quite siloed to dermatologists. I respect them enormously, and our dermatologists at GSTT are brilliant. But they don't do asthma, and they don't do allergic rhinitis, and they don't do peanut allergy and things like that. So, and those conditions are, you know, very, very common in that cohort, as you'd imagine. So that's where the allergist
And there's a
fits in.
lot of treatment required from
Yes,
both specialists
yes,
that isn't
yes.
easy for the other specialists to
Yes.
take
So
over.
we
Yeah.
we so we're much less, or we're not organ based. So we sit at the kind of
Mm.
interface and where there's sort of multiple allergic comorbidities overlapping. So if I see a patient in the clinic, it's not uncommon for me to, try optimizing their eczema care, to change their inhalers, to perhaps prescribe them their first ever EpiPen for their undiagnosed peanut allergy, and also to putting them on a steroid nasal spray and giving them antihistamine eye drops and all the rest of it. And it's actually sometimes the challenge is in information overload for the patient.
Yeah,
So
yeah.
trying to do everything in one appointment. But yeah, that's kind of what we do. Um, what we don't do is investigate patients who've got unexplained medical problems. So we do get referrals from patients who, um, we sometimes think we're the kind of last resort for getting a diagnosis in patients who've got things that have defied. explanation with other doctors, and that's really something that is difficult because that's not
I wonder whether the
suited.
patients are driving it. I wonder
Um,
whether they're so sort of
I think there's
desperate that and social media and health and wellness industry makes you think that these are all allergens.
so I think to some extent that's true.
Mm.
It's tricky, and there is an unmet need, of course, these
Mm.
patients, and sometimes they're very, a life is blighted by these things.
Mm.
We have a very finite resource of allergists in this country and vast numbers of patients with severe allergic conditions,
Mm.
and it's a difficult situation for us when it's not something that we're able to offer any insight into,
Yeah.
and I understand it's a kind of natural line of thought to think that perhaps an allergen is or allergy is
No,
driving this
I
thing,
don't think
but
it's a natural line of thought.
for
I think there's unfortunately a lot of misinformation out there.
mm,
And I think that's why it's important for us as clinicians to repeat this message that
yes,
when something is an allergen or when there's an anaphylaxis, these are clinical
yeah,
conditions that are obvious to diagnose, and that's when you see the specialist. And for other conditions that don't quite fit into that clinical history,
mm,
you're not going to be able to offer anything. And I think by repeating that at a specialist level, hopefully the message will trickle down to the general population.
yes, and we spend a lot of time very carefully vetting our referrals
Mm.
into our clinics because of non-allergic conditions, being
Sent your
uh,
way, yeah.
yeah, and it's and unfortunately we do have to turn down quite a few
Yeah,
referrals to
yeah.
us. So my colleagues, please
Well,
don't take it personally.
yeah,
But
yeah, sure.
we are shepherding a very sort of small resource and
Yeah,
trying to
yeah.
deploy it in the most effective way.
Of
So
course, that completely makes sense. But if the patients do want to see you privately, there is some use to the specialist saying it's definitely not this.
I hope so. I
Yeah.
hope so.
And
And
I think
mm,
as an opinion,
yeah.
privately perhaps you can do that.
So,
But I think
so
to
well, we do try to. I never would reject a referral without any explanation,
Well, no, but I think
and
that
to
that's the equivalent, because then you
yeah,
have the GP as the middleman saying,
yeah,
as I've spoken to this clinician, and the
yes,
clinician who is the specialist said that actually there's nothing that can be done from my scope of medicine.
yes,
But I think sometimes patients perhaps need to hear that from the horse's mouth. And
yes. I I think that's probably the case, yeah.
mm,
But of course, I think all of us in this situation also feel a bit sorry for our primary care colleagues who are
yeah,
kind
of
of
course.
sometimes, also stuck in how to best manage a patient who's
Yeah, and sometimes they're not
suffering.
believed as well.
Yeah.
Because they are the middleman. I think sometimes there's a lot of, at least what I'm sensing is dwindling sort of or a lack of trust, maybe because the response isn't coming from the specialist and it's
Mm.
just coming from your GP. That's a turn of phrase I hear often in my clinic
Yes.
that makes me feel slightly uncomfortable. But I guess we need to also acknowledge that we are better pattern recognizers because of our super um, sort of narrow
Yes.
field of clinical expertise. So
Yes.
yeah.
I mean, it's often the case that issues come up in clinic that I haven't the faintest idea how to manage, but a GP is perfectly competent at managing. My wife's a GP, so kind of often I'm asking her questions about these other things and where I should signpost the patient to go for these things.
Exactly.
So yeah, we all have skills in different areas. But you're right. I think, and I often wonder what it's like in other specialties. But sometimes I feel we have this kind of like very ultra narrow focus, and and yeah, we see the same. I mean, I guess that's what being a specialist is. You see a narrow range of
Mm.
conditions
Yeah.
repeatedly.
Yeah.
But one thing I've
So it
found,
gets really sometimes, I don't want to
well,
speak for you, sometimes it gets a bit boring for me. And that's why, again, why I wanted to
yeah,
talk about this on podcast, because I was thinking there are so many things that I say almost as a tape recorder.
yeah.
No, sorry, no, as a pre-recording, and then it just gets spewed out and I know it line for
So,
line.
so I perhaps I've got a short attention span, but
Yeah.
I don't find that I get bored of repeating the same thing. So one thing I've learned over the years, personally about myself as a doctor is that I'm really fascinated by the people I meet. And so they're even if they have the same, like these two patients with the wheat-dependent exercise-induced anaphylaxis, they occurred in completely different contexts. They had different
So
effects
you
on their
have the
life.
story
So
that
I
comes
like
with
the
it.
narrative, yeah.
Yeah.
And it's very important when I see my patients. For me personally, I like to know a bit about them,
Yeah.
and especially the younger patients. I always ask them what they're doing
Yeah.
for their A levels or what they're going to university and stuff like this. So that's very
You
important.
really do like
Kind of,
patient contact.
yeah.
Yeah.
So which is strange for someone who started off doing biochemistry and a PhD in immunology before doing medicine.
Okay. Well, maybe that's why you
So
like it, because there was just a
yeah,
dearth of human contact with those initial degrees.
probably.
I mean, and I guess I'm such an efficiency machine. I just thought, isn't there a better way of me capturing these recordings and then being able to play them on a bigger or a broader level, a higher level,
Mm,
so patients can access these as and when they require, or the general population as a health prevention tool or a health, to increase health literacy as well. So yeah, that's why I'm interviewing specialists,
yeah, that's a good
because
idea. I look
yeah.
forward to listening to the other ones.
Thank you very much for coming
That's
and
a
for
pleasure.
sharing all of your pearls of wisdom. And you haven't disappointed. Cos was right. You were a really good guest to have.
Well, thank you. No, I really enjoyed it. Thank you.